there? Okay. So I'm really honored to be here, and I've never given a talk in an IMAX theater, so this is a first. And I have a little vertigo here, but I hope I'm not going to induce it in you. But thank you all for coming on this rainy night, and I'm really delighted to be here to talk about people with severe brain injury and their struggle to get adequate care, and their need to be reincorporated into society. Because the story that I'm going to tell is one of tremendous scientific progress and equally tremendous societal neglect. And I'm going to argue that this is a civil rights issue of our time, that the needs of these people are really something we can no longer ignore. But before I get into it, I just want to pay a real debt to Professor Winsley. This book he wrote in 1998 was one of the very first books that I read on brain injury. I just started working with my colleague, Dr. Nicholas Shipp, who was here several months ago, and with whom I co-direct the Consortium for the Advanced Study of Brain Injury at Cornell. And I had the opportunity to review this book for the Hastings Center report in 1999. And this book really changed my life. Bill, I think, was really the first bioethicist to seriously write and think about brain injury. And this book, it's one of these books that didn't get all the attention it deserved because it was about 20 years ahead of itself, ahead of its time. So it was prophetic, it's still relevant, it's still inspiring, and it's still a great read. So don't buy my book, buy his book. I think it's still...
I'll pay you later.
Okay. But thank you, Bill, for inspiring another generation and for inspiring so many at UTMB over the years. You've been a singular force in bioethics in general and also here. Bill and I also share another thing in common. We are also American pragmatists, and I want to also nod to John Dewey, you know, sort of the leading American pragmatist of the 20th century, I dare argue, and really talk about how technology has really changed how we think about brain injury and our obligations to people with brain injury. John Dewey in 1938 said that inventions of new agencies and instruments, think of neuroimaging, create new ends and they create new consequences which stir men and women to form new purposes. And what we learned in the 30 or so years since I've graduated medical school has totally changed the moral and ethical landscape of what we owe patients with severe brain injury. And I'm going to tell you that story. Another aspect of this is how it affects the law. And Justice Kennedy, who just retired from the Supreme Court in Obergefell, an important decision about civil rights, wrote that new insights and societal understandings can reveal unjustified inequality within fundamental institutions that once passed as unnoticed and unchallenged. So what we took as okay and as normal, all of a sudden, because of science and technology and new insights and societal understandings, become unacceptable. And how we've treated people with severe brain injury over the years now I think is unacceptable. And I'm going to tell you that story. The interface between technology and science and how it's changed how medicine operates and changed how we think about diagnosis is an old story in medicine. This book over here, I'm sorry, I should have done that. I don't know how to get rid of that button here. How do I get rid of that button? Help me. Huh? Left click. Thank you, kids. There you go. Thank you. Who said that? You all pass with flying colors. Maybe you want to give a talk? You're the smart one there in the first row. This is Lynette's book on the stethoscope, and it's auscultation, hearing, okay? And this was the man who invented the stethoscope. When you go to your pediatrician and he listens to your heart and lungs, this is the man who discovered it. In 1819, he wrote this book. And this transformed cardiology and how we heard the heart and began to understand it. And our era is no different. We're now using imaging techniques, fMRI, PET scans, to look inside the brain. And what this has done is transform categories beyond describing what we see at the bedside into new ones. And this has created new ethical responsibilities and legal categories for these patients. So my talk is really going to be in 3 parts, and this should be 1, 2, 3, but it got scrambled in the Microsoft interface. We're going to talk about neuroimaging and disorders of consciousness and how we image the brain has changed our categories and understanding of brain injury. We're going to talk about the discordance between what we see at the bedside, how the patient appears, and what's going on, as it were, under the hood in the brain, and what that means. The second part, we're going to talk about how we intervene in the injured brain. I'm going to talk specifically about our work on deep brain stimulation, where we put an electrode in the brain and had an impact on a person who was severely brain injured. And third, I'm going to talk about why this matters and how rights come to mind. And to do that, I'm going to borrow from my book, Rights Come to Mind. It was published by Cambridge University Press. And I'm going to share narrative interviews with families who consented to be interviewed for this book. And I just want to say that this was approved by Institutional Review Board, and we have approval and HIPAA waivers from the families to use their names. If I don't say that, they take away my ethicist card. That's a joke. Okay. For those of you who are science nerds and you want to read a review article that we wrote with Nico Schiff and myself and Joe Giacino and Stephen Lauries from Liège, this was in Nature Review Neuroscience in 2014. But basically what I'm going to be talking about are these categories of brain injury. Brain death, which is whole brain death. Coma, which is the initial presentation of a severe brain injury. It's an eyes closed state of unresponsiveness. There's no awareness of self, others, or the environment. And then, after about 2 weeks, unless you're being medicated, you move into the vegetative state. And the vegetative state is a state of wakeful unresponsiveness. What a great phrase. The eyes are open, but you're not aware of what's going on around you. You look like you're awake, but you're not. And this is the isolated recovery of this part of the brain down here. It's called the brain stem. And depending on how long that lasts, it's either persistent or permanent. But the money category here is in green. It's the minimally conscious state. These are people who look like they're vegetative, but they're actually conscious. And that creates all kinds of ethical challenges, because if you think somebody's permanently unconscious or unconscious, and they're actually conscious, and you treat them like they're never going to get better, or you treat them like they can't perceive pain when they can, you're going to treat them badly. And it's a big problem. And the minimally conscious state is also the platform for additional recovery. Now, I have this image here, and it's interesting I have this podium here, because I can sort of have that same pose, and I'd be like a skeleton. And the reason I have it here is that this is a Vesalius print, an ancient artist, and what it shows, I want you to convey, is he's contemplating the anatomy of the skull, which is no different than my contemplating neuroimaging. And as outdated as this is, what I'm saying to you now is going to be outdated in a couple hundred years. And I should have the same humility about what I'm saying as we have about the humility of looking at this. So for you young guys in the audience who know how to left click, right? It's important to know that what you learn today, there'll be new information tomorrow. Knowledge evolves and changes over time. If that's the only thing you learn tonight, that's the most important lesson. Knowledge is not static, it evolves. And it's evolved, and it's evolved in my lifetime, and I'm going to show how it's evolved in the last month, okay? So this is our story. You lose consciousness, and you can become brain dead. And that's whole brain death, okay? And what I want to show is the discordance between how you look at the bedside and actually how you might appear on a neuroimaging scan. And I want to go through this sequence. So this is a brain death neuroimage, okay? And what you have here is what's called the empty vault, right? So the patient at the bedside has a heart rate, they're breathing on a ventilator, they're pink and they're perfused, they look like they're alive, but they're actually brain dead. And there's nothing going on the inside of their brain. They appear alive, perfused. In fact, one time, I saw this one time, patient was breathing, we had just done what's called an apnea test. We take them off the ventilator, we let the carbon dioxide go up 20 millimeters of mercury, and when the carbon dioxide goes up in your brain, if your brain stem is working, you take a deep breath. Not so much because you're low on oxygen, but because you're high on carbon dioxide. You want to get rid of the carbon dioxide. That's why people drown. It's not because they need oxygen. They need to get rid of the carbon dioxide. Okay? It's called a hypercapnic response. So patient fails that test called brain death testing. Okay? And the doctor, the pulmonologist, had just recorded all this information. And then the patient, everybody got, look at me now. All you kids who are sleeping in the back, look up. Patient goes like this. We just declared her dead, brain dead. And she goes like this. And someone said, Jesus. And no, the right answer is Lazarus. Because Lazarus rose from the dead. And it's called the Lazarus reflex. And it's a cervical reflex from the cervical spine. What's interesting is the pulmonologist who had just done all the testing goes over, reaches for his stethoscope to listen to the very lungs which he had determined were not working, right? Because it was counterintuitive. He didn't believe it. The neurologist did a body block, pushed him away. He said, that's the Lazarus reflex. You're never going to see it again. Don't ruin it. So here, the situation, the patient looks a whole lot better than their image, okay? So that's the kind of discordance we're talking about. Let's now move on to the vegetative state. The vegetative state was described by Brian Jeanette, who's known for the Glasgow Coma Scale, and Fred Plum, who was my teacher at Cornell, who was known for the vegetative state and the locked-in state. These are two giants. He's a neurosurgeon, neurologist, American and Scottish. And they wrote this paper in The Lancet in 1972 as a syndrome in search of a name. They described a state of wakeful unresponsiveness. And this is the isolated recovery of the brainstem, the vegetative state. But here, the imaging, the brain actually scans look better than the patient. Their eyes are open, but they're unresponsive to their environment. And here you see some heterogeneity, right? You see, these are all vegetative patients. And this is a paper that Nico and I, and actually Dr. Plum, were authors on. And you see how patients who have cardiac arrest and have low oxygen have lower metabolic activity in panels D and E, and people who have severe brain injury, traumatic brain injury, have large areas of metabolically active brain. This patient in panel A has a whole large area of cortex on the left side. And what's interesting is you point to this arrow, the patient is vegetative, not because of what's going on in the cortex, but because they lost their thalamus. The thalamus is the central nut in the middle of the brain that integrates the brain with itself. It is to the brain with Hartsfield Airport in Atlanta is to Delta Airlines. It's the hub. You can't get there from here if you don't go through Atlanta. I fly Delta a lot. If there's a problem in Atlanta, the whole system is broken up. Because we now know the brain is organized from cortical, thalamocortical tracts, back and forth, back and forth. So a structural lesion in the thalamus has significant implications. But the point here is you can have heterogeneity and discordance on image, but all these people are going to look alike, discordance, okay? And one of the things that you see, depending on how you've been injured, you have 3 months to the permanent vegetative state after a noxic brain injury and 12 months to the permanent vegetative state after traumatic brain injury, because these people who have had traumatic brain injury over here have more intact brain and they take longer to declare permanent. At least that's the story until September 2018. We'll get to the addendum in a little bit. Okay, let's now move on to the minimally conscious state. And the minimally conscious state was described in 2002. These are aspen trees from Aspen, Colorado. And these people are fascinating. This is the money category, as where these people are conscious, but they often appear vegetative. In fact, 41% of patients in nursing homes who are thought to be vegetative, this will knock your socks off, thought to be vegetative after traumatic brain injury are actually in the minimally conscious state. We get the diagnosis wrong 4 out of 10 times. Think about that. Imagine getting a leukemia diagnosis wrong 4 out of 10 times. It's tragic, okay? These people have intention, attention, memory. They might look up when you walk into the room. They might even say their name. They might reach for a cup. The challenge is that these behaviors are episodic and intermittent. So at any one time, they're not likely to demonstrate the behavior. So you actually have to do the testing about 5 times to get an adequate sample. If you're in a nursing home and the doctor comes in once a week and zips in and zips out and is not a neurologist and is a general practitioner, has never been trained to do this, there's a high likelihood he or she is going to get it wrong, especially if you left the hospital in the vegetative state, and everybody thinks that you're going to be that way forever. When in fact, as the image here shows, people move into the minimally conscious state after they get into the nursing home, if they move into it, and people don't think you can move. If you're diabetic, you don't go to the nursing home and get over your diabetes. But these aren't diagnoses, these are states, which makes it even more tricky. The poster boy for the minimally conscious state is a patient who I profile in the book. It was Terry Wallace. He had been in a car accident in 1984, was thought to be in the vegetative state until 2003, when he had a miracle awakening from a coma, vegetative state. Everybody used all this different language, but you know it wasn't true. In 2003, he started talking. His first word for mom, Pepsi. As a Diet Coke drinker, I object to that. Over the weeks, he had greater fluency. He was locked in time. He was like Rip Van Winkle. President Reagan was still president. It was 1984. But I reviewed his medical record. And in fact, he had been in the minimally conscious state probably 3 months into his injury, and everybody thought he was in the vegetative state. Why? Because there was no minimally conscious state. The category didn't exist yet. That's the point for you young people, you Padawans, you young Padawans. You know Star Wars, you young Padawans? Knowledge evolves. There was no category to describe what he was. And he was unassessed by a neurologist for 19 years, according to his father, because it wouldn't matter, wouldn't make a difference. He was permanently vegetative. He was not going to get better. He developed contractures because he didn't get physical therapy. His mind was getting better. His body was deteriorating. So when he started getting better, I tried to get him help. I called his congressman, Marion Barry from Arkansas, and I needed his Social Security number to get him services, Social Security, rehabilitation, and the like. And I called up Mrs. Wallace, who's given me permission to tell their story in the book. And I said, Mrs. Wallace, what's Terry's Social Security number? And she turned on the phone, at home in Arkansas, and she said, Terry, what's your Social Security number? And with an Arkansan accent, and I'm going to do a bad imitation, she said, Terry, what's your Social Security number? And she gets a number, and she tells me, and I write it down. And I said, Mrs. Wallace, was that Terry? Terry Wallace, the guy who'd been vegetative for 19 years, right? Is that Terry who told you what his Social Security number was? She said, yep. First time he told us, we thought he was wrong. We looked it up. He was right. Right? Where was he all those years? What was going on? That's what keeps me up at night. Should keep you up at night. This is Terry Wallace. And this is the challenge. Nosology is a fancy word for diagnosis, and it's reemergent self. Okay? The challenge is this story. This is a story that, one of the 2 stories in the book that just gives me goosebumps. So Mrs. Wallace gets a call that Terry's not right. It's the early 1990s before he wakes up. Okay? He's supposedly in the vegetative state. He's in a nursing home. The man in the other bed across the hall, across the room, old man with dementia, so it's a little upsetting for you kids, gets strangled up in the sheets and dies. He strangles himself. He's demented. Okay? So they're very upset, and Terry's upset, and the nurse's aide, not knowing that vegetative people shouldn't feel any upset because they're just wakeful and unresponsive, one mom to another calls Mrs. Wallace and says, you've got to come in because Terry's not right. So this is what she told me in the book. One of the aides called me from work one morning, told me she was not supposed to do that, little civil disobedience. That man had passed away that night, and that had bothered Terry. I needed to be down there. When she arrived, Terry was lying there with his eyes open wide. He would not go to sleep. I mean, he was making no noise at the time, but I stayed there with him most all the day until he finally went to sleep. So I don't know what he saw, but I know he saw something, and I know it had a now. This is after he had woken up. In retrospect, now I knew then it had to be something that was really bad. We now know with a reasonable degree of certainty Terry Wallace was already in the minimally conscious state when this happened and was perceiving this. But the challenge is there was no category for to describe where he was, and no one knew that this was possible. And there's thousands, tens of thousands of people in American nursing homes, potentially just like him, who are in this state, who are living in this kind of isolation. And here's an image of what happened to his brain. This is a phenomenal story. This is from 2006. This was on the front page of the New York Times. I want you to focus on the red fibers here. These are fibers in the brain that go left to right, that cross over. This is the corpus callosum. This is white matter that should go from the front of the brain all the way to the back of the brain, and it should be equally thick. And you see how it's kind of narrowed out and absent here, just how badly injured his brain was. And then there's a big glob of red stuff in the back of the brain, which should not be here. And you see it circled here. Over an 18-month period, you have this here, and it goes away, and you have new fibers down here. And this was possible axonal regrowth, late recovery in the injured brain, some 19 years after his injury. What does this look like? This looks like, how many of you guys are in elementary or junior high school? What's going on in your brain, guys? This is a developmental process. This is sprouting of axons, connections, and pruning. This is how your brain is growing. Isn't that amazing? This is how his brain is recovering. So this is the first time in history, in human history, that we've seen injured brains, because in the past, people like this kind of injury, they just die. Now we're able to keep them survive. We relieve their pressures, we keep them going, and now the brain is using a developmental mechanism, okay, that's going on in your young brains to help repair injured brains. And it's a dynamic process. Let's now look at brains in another way, the vegetative and minimally conscious brains, okay? This is the difference between a minimally conscious brain and a vegetative brain, okay? This is a study that was done by Stephen Lories in Liège in Belgium. And what he did was demonstrate that a vegetative brain doesn't have a network response. When you press on a nail bed and you cause some discomfort, in a normal person, you light up the pain network, and that's in red, okay? In a vegetative person, you just light up the primary sensory area, and blue is the absence of activation. So the network response, which is how our brains work, it's like a network, like a grid. It doesn't activate. In contrast, this was a study done at Cornell. When you take a minimally conscious patient and you play them language, forwards and backwards, okay, on a tape, right? So it's the same frequency. You play it forward, or you play the gibberish backwards, it's the same frequency. They respond forward to the language, to the syntax, to the grammar, to the content. And it shows their ability to process language. It's a network response. And it means they're able to be in the room. They're hearing and understanding what you're saying. I was interviewed for this, and this was on the front page of the Times, right at the time of the Terry Schiavo case, and I said the following, and it should give you goosebumps too. This study gave me goosebumps because it shows this possibility, this profound isolation, that these people are there, they've been there all along, even though we've been treating them as if they're not. So they're here, they've got a network response, they're processing language. Even though, if you look at them at the bedside, 4 out of 10 times, they look like they're vegetative. They look like they're unconscious, but they're processing language. Think about the implications of that. Okay, couple more stories. This was studies. This was done by Adrian Owen in Cambridge, and basically a patient who was in the vegetative state behaviorally was asked to do the following test. Imagine yourself walking through the house, imagine yourself playing tennis, and imagine yourself disaggregating words that sounded alike, okay? And the patient who had a vegetative exam lit up her motor area when she was playing tennis, sensory area, spatial area when she was walking through the house, and linguistic area when she was trying to figure out these words. And it was the same as normal. And we described this, Nico and I, as non-behavioral MCS, the ultimate discordance between what you see at the bedside and what's going on in a person's head. This same method was used by Martin Monti a couple of years later as a communication channel for a patient who otherwise could not communicate. And they said, imagine tennis imagery, playing tennis for yes, and imagine walking through your house for no. And with this neuroimaging technique, with this scan, they were able to allow a person who otherwise would have been mute, unable to communicate through this neuroprosthetic, this technology that allowed for communication. Now, here's the paradox. Would you say some of this is interesting? Anybody think this is uninteresting science? Do you think it's uninteresting? Do you think it's interesting? Yes, you think it's interesting? Okay, everybody thinks it's interesting. But the healthcare system doesn't think it's interesting. okay? These people are presumed to have a bad outcome, all right? When you get injured, there's a presumption you're going to do badly, that the brain doesn't change over time, despite new scientific information to the contrary. There are early decisions to withhold or withdraw care, to turn brain-injured people into organ donors. Organ donation is important, but not in a way that's unthinking and unnuanced. And people who leave the hospital are discharged while medically unstable. So the question is, why? Why? This makes no rational sense, but it's happening all the time, despite a lot of progress. And the reason for that, I think, is that bioethics has evolved since the 1960s, predicated on the evolution of self-determination and choice. And it evolved as a negative right to be left alone in the right to die movement in cases like Karen Ann Quinlan, who was a young woman in New Jersey who was in the vegetative state, and the right to die and the withdrawal of care in a fetal case was predicated in that case on the loss of her ability to think, a loss of her cognitive sapient state. And Dr. Plum, who was here in 1976, again, my teacher, and testified in the case because he discovered the vegetative state just a few years earlier, and Judge Hughes' court in New Jersey said it was indicated by Dr. Plum that the brain works in essentially two ways, the vegetative and the sapient. The vegetative, the sort of autonomic stuff, and the thinking part. We have no hesitancy to decide there's no external compelling interest of the state should compel Karen to endure the unendurable. Because if you're vegetative, you're not enduring anything, but we'll give him partial credit because it was 1976. That's a joke. Only to vegetate a few more measurable months with no realistic possibility of returning to any semblance of cognitive or sapient life. Okay? Very important decision that launched the right to die movement in America. And over the ensuing years, doctors became acculturated to the right to die. The vegetative state became the ultimate in medical futility. Nothing can and should be done for these people. These injuries were immutable. And the brain was thought of as a gelatinous gel. In fact, when the Karen Ann Quinlan autopsy was published in the New England Journal of Medicine, her brain weighed half of the normal brain. Her cortex was thin. It was full of liquid. And it was not the substrate for any additional recovery. And this held in other severe cases, the Cruzan and Shivo case. But we had what we call a neglect syndrome. In neurology, if you have a certain kind of injury, you have a neglect syndrome. So you don't see half of your visual field, but you don't know you don't see it. All of a sudden, we were seeing these cases that broke the rules and people who got better after a long period of time. And these were the minimally conscious patients who were somehow different than the vegetative patients. Now, this story of neglect and optimism, okay, between hopefulness and despair is an old story. It doesn't start in the 1960s with the advent of bioethics. It goes all the way back to Hippocrates and Galen. And Hippocrates is a famous doctor who did the Hippocratic Oath, and Galen was his most important student in the 4th century Galenic Pergamon in the Roman era. This is a very important painting. This is the ceiling at the Montreal Neurologic Institute, designed by Wilder Pinkin, a very famous neurosurgeon and neurologist who founded the Montreal Neurologic Institute. And he designed this as his cathedral ceiling at the entryway. Inside is an early representation of the brain, a ram's head, hieroglyphics, and around the periphery in Greek is the Galenic refutation or disagreement with the Hippocratic aphorism that all brain injury is invariably fatal and very serious. But Galen said, "But I have seen the injured brain healed." Now, as a doctor who does medical ethics, and we all take the Hippocratic Oath, which is all about ethics, you think I'm a Hippocratic doctor. But on this one, I'm going to vote for Galen, because I have seen the injured brain healed, and so have you. This is healing in the injured brain. Brain injuries are not immutable. And my student, Zoe Adams, who's now a second-year medical student at Yale, and I wrote an article that appeared in Neurology last year explaining why Galen felt this way. He had actually done experiments with snails and seen snails heal after compressing them and recover. He had seen the injured brain heal, and we have as well, and so have you, and I'll show you some more. Here's another story about a man who recovered in a most dramatic way. This is Don Herbert, who was a fireman, was in a fire in Buffalo on December 29th, 1995. He had got hit on the head, was wearing an oxygen mask as a fireman. And just very briefly in 1996, he had some rare speech. And then he went into what was thought to be the